Hello, I'm David Healy, and this talk that I'm about to give on that collision between ADHD and ASD on the one side and disability benefits on the other feels like just about the most awkward talk I've ever had to give. It's a tricky problem, not really complex so much as tricky, with no easy answers. This report you see here appeared in the UK last month. It's a 444-page report. It's only part one of two parts. And it's saying that the UK is on the verge of going down the tubes almost. It's going to lose a generation, supposedly. There's going to be a whole load of younger people in particular who aren't ever going to end up in work, either because there aren't any jobs there for them, or they aren't able to get into jobs, or they aren't able to maintain the jobs. And a great deal of the problems put down to issues like ADHD, attention deficit hyperactivity disorder, and ASD, autistic spectrum disorder. So one of the things that politicians in the UK aren't going to look at, but I think they probably need to look at and think about is this. The problems as I see them go back to this book here, DSM-3, which appeared in 1980. And it introduced the concept of operational criteria. And it did so because in the United States at that point in time, the mental health scene had the Freudian therapy scene and the drug scene had begun to emerge. And the two sides couldn't talk to each other because the Freudian said, well, we've got neuroses and ids and egos. And the med people said, well, we've got serotonin and dopamine. So the agreement was, let's focus on things we can observe. Can you sleep? Can you eat? Have you got energy, etc., etc., etc.? And in the case of being depressed, if you've got 5 of these 9 things that we can observe, we can agree that this patient has depression. Now, that was fine in 1980. The judgment about whether you had these 5 features because you were depressed rather than because you were pregnant lay with the doctor you were seeing. But for a lot of people who are harmed by drugs, leaving it up to the doctor to decide what's wrong with you doesn't necessarily feel like a good thing. And in 1987, the DSM changed that so that rather than your doctor having to decide on the idea that you're depressed rather than pregnant, he or she could use the same set of symptoms to say, well, you're depressed and pregnant. Now, this opened the door to the rest of us being able to say, well, I've looked at these criteria as well, and I think I'm depressed, and I've got ADHD. ADHD was a new disorder that had been introduced into DSM-3. And up till then, people could only either be depressed or have ADHD. But after 1987, you could have both. And that has had enormous consequences. Now, let me introduce one more terribly highbrow issue before we get down to the real story. The Netherlands, Holland, has led the way in terms of people having ADHD and ASD, and also led the way in people getting euthanasia for mental disorders. And they keep a track on who's getting euthanasia for what. And this is the annual report from 2024, which in the middle of it lists an 18-year-old boy who's got euthanasia for ASD. And it's on the basis that ASD is a supposedly incurable illness. The problem is they don't tell us whether he's had ASD from birth or whether he's only recently developed ASD or been given the label, in which case the whole situation becomes terribly tricky. The idea that we've been given this label for an incurable illness when we may not have the incurable illness. So part of what's going on here links back to the Holocaust. That'll sound awfully dramatic, but In this book you see here on the left called Modernity and the Holocaust by Zygmunt Bauman, Bauman said, look, when we think about the Holocaust, we shouldn't think of it as a picture of something that went badly wrong in our past. We should think of it as a window looking through to our present and our future. And he said that Max Weber in 1920, 20 years before the Holocaust, had anticipated the Holocaust by saying, once we develop technologies, the temptation to use them can become close to irresistible. And in the Holocaust, we sterilized 360,000 people and terminated the lives of 170,000 people whose lives we viewed as not worth living. And this was before the Nazis began to exterminate the Jews and other minority groups. This was all done on a public health basis. The Nazis introduced the idea that you should not be allowed to smoke. This was bad for your health. They were also looking after the genes of the population and figuring, well, if we've got people who've got mental handicap, these people don't have the kind of genes that we want passed on. And they weren't the only country in the world thinking about doing this at that time. Other countries like Sweden were thinking about it also. And the other point to bear in mind is that at this time, German medicine was viewed as probably the leading medicine in the world, the most sophisticated in the world. So if a very good healthcare system can end up doing this, and if this kind of problem began to appear in the 1940s and is better seen as a window through which we can look at what's happening to us, these are things that we need to bear in mind. And one of these sophisticated German doctors who looks like a nice man here was Hans Asperger, who created the concept of Asperger's syndrome, which was a mild mental handicap. And the children who had Asperger's syndrome, or what would be called autistic spectrum disorder now, featured heavily in among the children whose lives were terminated in the early years of the 1940s, and who also ended up being sterilized. Now, that's terribly highbrow stuff. Let me return to the real world. And the ADHD that was introduced as a new illness into DSM-3. If you want to read more about this, on the samizdat.org website, under the heading Psychopharmacologists, you've got a bunch of interviews with over 100 of the people who helped shape the world in which we're living, helped shape the medical world in which we're living now. And as regards what's happening in child psychiatry in the United States at this time, the most sophisticated medical system in the world then, we thought. The interviews with Judith Rappaport and Rochelle Klein are really well worth reading. If you want to know more about the idea of operational criteria, and in particular about a man who was probably the first to introduce them into the mental health domain, there are interviews with Bob Spitzer and Stan Guzet and Mandel Cohen, a name that very few people have heard about. So ADHD was introduced into DSM-3, and it became possible to say this is an illness for which doctors could get reimbursed. The pills that you could use to treat it, like Ritalin and dexamphetamine, were terribly old pills that the pharmaceutical industry couldn't make much money out of. So the challenge for them was to work out how to introduce isomers of these older drugs, or extended release formulations of these older drugs, and patent them and charge much more for them than they were able to charge for the older drugs. And this is Ritalin rebranded, and this is dexamphetamine rebranded, and there's Adderall and Vyvanse and a whole range of other pills, which, as I say, the companies were able to charge far more for these than for the older drugs. And as a result, what you see in the United States compared to anywhere else in the world, Europe, UK, Asia, that stimulant prescribing for children rose dramatically, and the amount of US dollars companies were able to earn for these drugs also rose. So this was a lucrative market, into which an oxetine was introduced. Now, what's an oxetine? Well, back in the early 1970s, Eli Lilly had a drug called nisoxetine and a drug called atomoxetine and another drug called fluoxetine, which is Prozac. These were all drugs that were designed to inhibit norepinephrine, noradrenaline reuptake in the first instance. But then Lilly, towards the end of the 70s, figured maybe inhibiting serotonin reuptake would be a better idea. But they didn't leave the noradrenaline reuptake inhibitors on the shelf. They started thinking, well, if we're not going to use these to treat people who are depressed, what could they be used for? And a man in the company called John Heiligenstein recognized that some doctors have been saying noradrenaline reuptake inhibitors can be good for people, young children who've got ADHD. And there was a further idea beginning to come on stream at that time, which was maybe children didn't grow out of their ADHD. Maybe adults became ADHD also. So here's an advert for Strattera. That's atomoxetine for children who have ADHD, and it's very like the kind of adverts you'd have seen for Ritalin and Adderall at that point in time. But Lilly were on their way to doing clinical trials for atomoxetine in adult ADHD. And that was helped by this book that you see here, which appeared a year before Listening to Prozac came out. And this book had a bit the same impact, although you don't hear about it quite as much. And if you look beneath the main title there, you'll see that it's recognizing attention deficit disorder from childhood through to adulthood. This was introducing the idea that to the wider US public that we didn't necessarily grow out of our ADHD, which had been the traditional view up till then. And linked into this, during the 1990s, we had a time when things were changing from the psychobabble of the Freudian era to the biobabble that we now have linked to the meds we're giving, the idea that there's low serotonin in people who are depressed. This is all meaningless. The adverts that you see here were the same kind of adverts for atomoxetine as for the stimulants. And it was a marketing of fear, which you see in the two adverts there in the middle, which is, if you don't treat this awful illness, either depression or ADHD, you're going to go on to a life where you fail in your career, you fail in your marriage, you become alcoholic, you use drugs, you commit suicide, you have car crashes, and this, that, and the other. You must treat this illness. And the two adverts on the extremes show you that you don't have to give up being depressed anymore. You can be both ADHD and depressed. So you can have both an SSRI and a norepinephrine reuptake inhibitor or a stimulant. Now, around the same time in the UK, this is a British Association for Psychopharmacology meeting that I organized and chaired. And the idea was to try and get people who were experts in giving drugs to children and regulators from the United States, from Europe, from the UK, and also experts in therapy to meet in the same room and to come to a consensus. At that point in time in the UK, there was no such thing as adult ADHD. Very few children were thought to have ADHD. One of the big problems, though, was if you wanted to treat the ADHD, you couldn't use stimulant drugs, which were controlled drugs. So it was very hard to, do anything much for these kids. Family therapy didn't always work. So what we were trying to do was find a consensus between therapists who were at the meeting also and other people from the States and all where they were using drugs. And the consensus, which I thought was reasonable, was that couldn't everybody buy into the idea that, well, you might begin with therapy, and if it didn't work, you shouldn't persist with it. You should try a pill and see if that made a difference. And equally, the other way around, if you happen to have begun with a pill and it didn't suit the particular child you were treating, you shouldn't persist. You should switch over to therapy and see if that worked better. And the group as a whole actually did sign on to that. Now let's hop from ADHD to autism, which around the same time as Hans Asperger was talking about Asperger's syndrome, which we now view as a mild kind of autism on the autism spectrum, Leo Kanner had introduced autism in the United States. And he billed it as a problem, a severe mental handicap linked to frigid mothering. This is a very Freudian point of view. It was a rare disorder. It was 1 in 10,000 children. And we didn't need to pay too much heed to it while it was that rare, but in the years that followed, it became less rare. And as it became less rare, people began wondering what's going on. Was there a gene for autism? Were we exposed to things in utero that could be causing problems, like heavy metals, maybe? Was it vaccines that was causing the problem? And the idea of vaccines came about because a lot of people were saying, look, my child was absolutely perfect up to the age of 15 months. Then he had a vaccine and hasn't been the same since. And some people pointed to the heavy metal, the mercury used as a preservative in vaccines as the cause of the problem. Looked at infections, we talked about serotonin. And there was a popular view back then that being depressed was linked to low serotonin and having autism was caused by having high serotonin. Things changed again in the 1990s when Lorna Wing in particular championed the idea of an autistic spectrum disorder. And this was folding the Asperger type milder mental handicap in with the more severe autism type pictures to say it's all one broad concept. And as that began to take hold, the incidence of the frequency of autism increased from 1 in 10,000 children to 1 in 2,000 children. And more recently, the kinds of figures you see, it's come down to 1 in 38 children. One of the other people very heavily involved in trying to promote the idea of autistic spectrum disorder was Uta Frith, who recently wrote an article saying, look, I was heavily involved in trying to promote this idea. It seemed useful at the time, but it's gone much too far. If we're talking about 1 in 38 children having ASD, something's badly wrong here. They don't all have a mental handicap. Now, let me switch again slightly to this man here, James Wilson, who in 1959 brought out a book called Principles of Teratology. This is the science of looking at things that might injure us in the womb. And the year afterwards, with others, he formed the Teratology Society. This put efforts to try and work out what might be causing birth defects on the map. And just after that happened, it became terribly clear that thalidomide was a drug that was causing gross birth defects. And one of the other drugs that helped raise the profile of this whole area was DES, diethylstilbestrol, a drug that was being used during the 1950s and 1960s to stabilize pregnancies. But then we found out that the daughters of mothers who'd been on this children developed a vaginal cancer that seemed linked to the DES. Prior to all this, we were aware that radiation could maybe cause a problem to children in the womb, and vitamin A deficiencies could, but very few drugs were thought of as being likely to cause a problem. During the 1960s, the idea that some of the antidepressants which worked in the serotonin system back then might be causing problems emerged, but no one paid any heed to it. Bendectin was the next big drug, which was a drug that appeared to cause in the first place gross birth defects also. Nobody thinks of that as being a serotonin reuptake inhibitor, but it is. And then by 1982, we'd reached the point of figuring that there's a thing which we should call behavioral teratology, which is if drugs cause gross birth defects like heart problems or missing limbs or whatever, that in lower doses or milder forms, they'll cause behavioral problems. There may not be any obvious birth defect, but the children, even though they don't have an obvious birth defect, could have behavioral problems. And the idea of behavioral teratogenicity began to grow during the 1970s and 80s, linked in particular to anticonvulsants. And the most famous anticonvulsant causing problems here was valproate. The other drug that seemed to cause problems was fetal alcohol syndrome. And you'll hear more about that soon. So this is my most complex slide. You don't need to pay too much heed to it, just the bit on the right-hand side where you see 2 tall bars and 2 small bars. We've ruled out the idea that autism is caused by a gene. We're now very aware that there are loads of genes, up to 250 genes, which might contribute a little bit to a problem. And this is all part of what's called epigenetics, where it's not just your genes that cause a problem, but it's the interaction between your genes and other things while you're in the womb in particular. And these can be drugs that you take, etc. And the big column that you see there on the right-hand side is sodium valproate, which acts on or has effects on 130 of these 250 genes. There's nothing else quite like it. The column to the right of that, which has an 8 on top of it, is mercury. And you see, this is the big thing that we were awfully worried about at one point. Well, at least epigenetically, it's really not making much difference. And the column on the far side of it, the one that has 92 over it, that's Tylenol, paracetamol, acetaminophen. And this is the next big problem after valproate. Now, I said anticonvulsants cause a problem. Well, what very few people know is that paracetamol is an anticonvulsant. SSRIs also seem to cause problems, not as bad as the anticonvulsants, but very few people realize that paracetamol also works in the serotonin system. So as behavioral teratology came into the frame, you'd expect us to have become more and more concerned about the drugs that people were on during pregnancy, but it was just the opposite. The traditional wisdom through the 1970s was you need to avoid taking drugs when you're pregnant, and in particular the psychotropic drugs. FDA was saying this, the American Medical Association were all saying this, most of the research that was done was saying this, and in particular also saying depression does not cause birth defects. End of story. Around 2006, things changed. People began saying, if you're on antidepressants during pregnancy, you need to keep on taking them. Antidepressants don't cause birth defects. Depression causes birth defects. And FDA, who used to have pregnancy categories for drugs, A, B, C, D, and X, pointing to higher and higher risks, got rid of the pregnancy categories. So what's going on here? Well, this is part of what's going on, but you're going to see a little bit more now soon, which is this is a statement put out by the American Psychiatric Association and ACOG, the American College of Obstetricians and Gynecologists, saying, whatever you do, you should not stop your antidepressants during pregnancy. If you've got a moment's misery or anxiety, this might do harm to your child. Do not stop your pills. It's you being anxious or low in mood that can cause problems. So this is a big change from what happened before. And what's going on in the background here is we've got the SSRIs, antidepressants, being used more and more and more. And you've got slides like this being produced in articles appearing in all the best journals saying the problem is leaving depression untreated in pregnancy. If you do this, it's going to have an effect on the fetus in the womb. If you do this, women who are depressed are going to go out and smoke and drink and take drugs, which is all really hard to believe as we see. The other thing is that they aren't going to eat properly. Now, this betrays what's going on here, which is if you do your screening for these kind of things in deprived, poverty-stricken populations and give them a Hamilton rating scale, they'll all come out as being depressed. Life is hard. Life is difficult. Yes, I'm anxious, etc., etc. But the reason the children will have problems is because of the poverty, not because of an untreated illness. This kind of thinking was not just a thing going on in the United States. It spread worldwide. This is one of the offshore islands. This is the UK. And here's a book from very respectable people saying exactly the same things in 2009. Now, here's the point. In 2009, GlaxoSmithKline, their Paxil, Roxetine, they lost $1 billion after a legal case where the jury decided, yes, it had caused birth defects and they had failed to warn. This is what's been going on behind what you've just seen, which is the big move to say antidepressants aren't a problem. The only problem is leaving your illness untreated. And here's an extreme example of that from a group that are notorious for their extremes. This is the Mother Risk Group linked to the University of Toronto, who never have seen a problem with any drug at all given to women during pregnancy. And this is a 1998 article, so this was quite early, saying SSRIs are no problem at all given to women who are pregnant. The data in the article shows that, well, there's a doubling of the rate of voluntary terminations of pregnancies in women on SSRIs and a doubling of the rate of miscarriages. So it's hard to see how you can claim these drugs are no problem. But the main man behind Mother Risk was a man called Gideon Coren, who pushed the boat out even further in this article here, where he proposed the symbol you see there in front of you, which is we should put an image of a pregnant woman on all of these pills, get over their neuroses about taking pills during pregnancy. Coren has since been fairly comprehensively disgraced, but around this time he was being consulted by lawyers for GSK and all of the other major pharmaceutical companies. And here's something exactly the same linked to acetaminophen, Tylenol. Kenvue, the name you see down at the bottom left, is Johnson & Johnson in disguise. And they were the people who were marketing Tylenol. And here is where they're mapping out the defense for Tylenol and the idea that it could be causing ADHD and ASD. And the defense involves partnering with all the groups that you see here, which include groups like ACOG and APA and autism groups and things like that, to persuade them that the science shows there is no problem here and they don't need to pay any heed to all of these things that they see turning up in the media. This is very like what the APA did when FDA were pretty well forced to put black box warnings on the SSRIs and other antidepressants for children in particular. And APA rushed out this news release saying that we believe antidepressants save lives. This has always hit me as a professional suicide note, and it's hard to understand how they don't see it this way themselves now. What they should have written was that psychiatrists save lives, and save lives by exercising a degree of judgment over whether you're taking too many risks or not here. So after the Kilker case in 2009, which said Paxil causes birth defects, a few has decided to look at the studies that were out there at that point, saying, well, if it causes birth defects, does it do what people have been saying for a while? Does it cause behavioral teratogenicity also? ASD, in essence? And the answer is, from these case-controlled studies that you see here, yes, it does. It doubles the rate of ASD in children born to mothers who are on SSRIs during pregnancy. And if you look at the case-control studies, you get the same result. It's a doubling of the rate of ASD compared to born to mums who are on SSRIs during pregnancy compared to mothers who are not on them. The most interesting result is the one there that you see in the upper right with the X beside it. This is by Heidi Mam and colleagues, who which is probably the best study. It's got a very tight confidence interval. But the oddity, there's an oddity to it, which is they have a footnote where they omit their most striking result, which is that they say at the footnote that there was a 10-fold increase in the rate of fetal alcohol syndrome disorder in mothers taking SSRIs compared to mothers not taking SSRIs. And they couldn't explain this, so they just noted it. And if you know about the recent Canadian guidelines for the use of SSRIs in people who've got alcohol use disorders, they now say very, very clearly, SSRIs can cause alcohol use disorder. And if somebody has begun to drink after going on an SSRI, stop it. And in people with alcohol use disorder generally, for the most part, don't even think about starting an SSRI. So I think this speaks very powerfully to the effect of SSRIs, which may not be necessarily causing ASD solely on their own, but through increased use of alcohol and things like this, they may be leading to things like ASD. And if you remember, the message from GSK and others was, well, no, women whom you don't treat will get fetal alcohol syndrome. In fact, it's the other way around. Now, in the article we wrote about SSRIs and ASD, now, we didn't include ADHD. I forgot to mention earlier on, one of the technologies that Nazi Germany was famous for and has become even, a thing that we've got better and better at ever since is a technology called marketing, our propaganda, our fashion, if you want. Now, in the ASD paper, we just looked at ASD because it's a hardcore mental handicap, or was. ADHD isn't, okay? So when you look at ADHD and ASD following paracetamol, you get results that are all over the place. Some big studies saying yes to the problem, some saying no, there isn't, with ADHD in particular. When, however, you look at animal studies of animals given Tylenol during pregnancy or animals given SSRIs during pregnancy, they universally show cognitive delay in their offspring. They show neurodevelopmental disorders. So in our ASD article, we included these animal studies here. And the article was turned down by BMJ, who said, we don't deal in animal studies. We only deal in human studies. And in this tricky ADHD area in particular, and ASD, as you'll see, part of the helpfulness from animal studies is that animals don't do fashion. We do with illnesses like bipolar disorder. We can have a flood, an epidemic of bipolar disorder, which is here for 1 year. Well, it's here for about 10 years, and then goes away to be replaced by other illnesses. Animals do neurodevelopmental delay on its own very well. Now, this leads me back to the UK and the scene in the UK as of 2009. That's over 10 years after the BAP Consensus Conference. I said, back then, there was no adult ADHD in the UK. And in 2009, there was still no adult ADHD in the UK. So I did this interesting little study, which was to write to all the consultant psychiatrists in North Wales and ask all of the 60 of them, did they think there was any such thing as adult ADHD? And to a person, they answered no. I also asked them a strange question was, will you think that there's such a thing as adult ADHD in 5 years from now? And the answer was 50%. Well, all bar two actually said, yes, we will think there is such a thing as adult ADHD. This shows the powerful effect of fashions. You can see what's going to be fashionable next year. And we asked them, will you be treating it? And half of them said, yes, they would be treating it. And part of the reason why they would be treating it and their sense of the way the game gets played these days is it's not just articles and things like that, which influence people. These articles on clinical trials, all done by the pharmaceutical companies, which the nice guideline apparatus and regulators don't see the data from, and which can often be fraudulent, get built into standards of care, get built into guidelines. And a few years after, up till about 2018, the nice guidance for the treatment of ADHD said it's mostly children, maybe a few adults, and you should start with therapy first and then move to pills if the therapy is not working. But here in 2018, the story has changed completely. You are being told that if you don't agree there is such a thing as adult ADHD and it's common, and if you aren't treating it, you face being sacked and probably deserve to be sacked. So if you're a doctor caught in the middle of this, you can see why people might think, the way the world is going, this illness will exist in a few years' time, and we will be treating it. And that's shown to some extent in this graph here, which is the diagnosis of adult ADHD, well, of all ADHD, and the use of drugs to treat it as of 2021. And as of then, it was still more common in boys, teenage boys, than teenage girls, as you see down at the bottom. But it was also becoming a disorder of adulthood. And as it becomes a disorder of adulthood, it becomes a female disorder. And it's now a case that this is now the only illness in medicine that I know of, which has got one sex prevalence at a young age and the opposite at an older age. And just look at the four tiny dots up on top from the ages of 60 up to 90. There's very few people in older years who have old age ADHD. That was back in 2021, but things are changing. Here's a graph from 2021 on to the start of 2026, showing you the increased numbers of people who are being diagnosed with ADHD, and they've doubled. And this is not because we have more children who have ADHD. We've got less and less children these days. So this is adults contributing to the picture. And if you look at the orangey line, that's the money being made, the cost to the government of the meds being used to treat ADHD, which is also doubled. But that's a small amount of the cost to the government. As you'll see, I've got my slides slightly out of whack here. This is was the strongest finding in all of the social sciences. 600 studies are behind the blue line you see there, which is showing you that benefit claims peak in people's 40s and 50s. They're linked to musculoskeletal problems, and when people retire, they don't claim disability benefits anymore. They get the retirement pension. That's all changed as of 2019, where all of a sudden you've got the people most likely to be claiming benefits are in a younger age group before the age of 40, and they're claiming them for mental health reasons. ADHD, ASD, these are the ones that are growing most rapidly. So what the government spends on pills is one thing, but it's actually spending much more money on benefits. And as the report you saw at the start says, it's 25 times the amount of money being spent on benefits as is being spent on trying to help people into work. Of course, there are reasons why, well, I'm going to end on this note, which is that real disabilities are increasing and we need to pay heed to this, but also polypharmacy is increasing. So these younger people with these other illnesses, there is a problem here. They may not be able to work because of all the pills they're on. And in terms of people ending up on pills that you wouldn't expect to be on pills, I've gone back here to this slide. This is the Carlat report, which for a lot of doctors in the United States in particular this is the place to turn to for a view that's going to keep us independent of the pharmaceutical industry. That's the way the Carlat reports began, but it's not really what they look like, at least to me now. They look like, well, these could all be written by industry people. And the image here just shows you what the Carlat reports look like. The quote comes from a Carlat report just last month. And I mentioned older adults. The latest issue of the Carlat report says ADHD is alive and well in people in their 80s and 90s. You might think it's because of old age that they're losing attention, etc., etc. You need to stop thinking this way and recognize that they've got ADHD and put them on stimulants. Now, the key point here is this. Back 30 or 40 years ago, if I went into a residential home where a lot of people had dementia, you'd see people walking from one end of the room to the other and back and back and back and back. And if you give them a stimulant, they'd sit down. If you see children who are hyperactive around the age of 4, 5, 6, 7, like bees in jam jars, and you give them a stimulant, they quieten down instantly. And this is where the idea of hyperactivity disorder came from. If you've got a manic patient who's racing around the place, tearing things up, doing all sorts of things that you wish they weren't doing, and you give them a stimulant, and most people would say this is exactly the wrong thing to do, they quieten down. So there's an issue here that has nothing to do with illnesses. And saying that just because you've had a response to a drug, this means that you have that illness is wrong. Stimulant drugs can be used in cases of overactivity or underactivity. Both can be helped with these drugs without meaning that you've got an illness of any sort. So let me take you forward. Now, this comes to almost the end of the talk. Just one more theme being introduced here, as it were, but the last one. Back a few years ago, Samizdat published this book by Patrick Hahn on ADHD, and it was about the history of childhood ADHD in the United States. Patrick doesn't take hostages. He tends to be black and white. He sees this all as a bad story rather than a nuanced one. But he writes well, and there's a challenge here to people who think the other way around, that therapy is better or whatever. He thinks therapy is better, but there's a challenge to people to come to a consensus. What does this tell us about what we're doing here? So on this basis, I reached out to a bunch of people who were prominent promoters of the idea of adult ADHD and said, look, we've just produced this book. We'll publish anything you have to say about it. You might say this is utter crap and should be burnt, and we'll publish it. The idea was to get a conversation going, but the response was nobody picked up at the challenge. We were told that this is going to contribute to stigma against ADHD. This was very like the response you got at this point in time from people who are in the transgender debate. Anyone who wanted to talk about what's going on, and you didn't need to, be hostile to the trans issue to figure out there is a thing here that we need to talk about, got accused of being transphobic. There was no debate no debate possible. And it's very much the same with ADHD. People aren't particularly open. If you're involved in this year's fashion, you tend not to want to think that it's not your own choosing, that you've been maneuvered into it. So you see here that our contact gave us a video to orient us. On the blog post version of this talk, there's a link to the video, so you'll be able to see this. Now, around this time at work, I was increasingly faced with young guys at university, one in particular I can think of, who told me he had ASD. And I listened to the history, and he was involved in the university and all of the social clubs that are in the university. He was easy to chat to. He had no gaze avoidance. He had a sense of humor. He just, well, it was hard to see him as having ASD. So when I thought gently hinted that maybe he doesn't have ASD, his response was, look, you're an old guy. You're not up with the latest research. I'm up with the research, and I know I've got ASD, which from a DSM-3 point of view is fine for him to think that. But the job moving forward is to find, well, to see can we find some common ground. A different lady, also in university, told me in one clinic visit that she had 17 different disorders. I was a little surprised at this and said, can you give me a list? And she emailed me over a list of the 17 disorders she had, which included both ADHD and ASD. Now, in the world I'd come from, and in the world I guess I was still operating in to some extent, you couldn't have 17 different disorders. But anyway, she did. And this is part of the problem we're up against. It's a new world for an old dude like me, and I've got no clear answers on how we handle this. But here's an extreme version of what I've just told you about, and something that caused my jaw to just drop completely. The Cochrane collaboration was created in 1992 as medicine's ultimate defense against the pharmaceutical industry, a way to corral industry, to make sure that they were being honest, keeping them honest. I mean, we know they want to be honest, they need a little bit of help sometimes. And what Cochrane used to do was to take all the trials that have been done, wean out the double reporting of trials or triple reporting of trials, or wean out the fact that sometimes trials are reported up to 50 different times in 50 different kind of publications, boil them down to just the few trials that are really there and work out, well, what do these trials tell us about how well this drug works or not? And, this was a great service to all of us when it began first. But here's Cochrane's death knell, I think. There's a group who have recently done a Cochrane review on noradrenaline reuptake inhibitors. That's principally atomoxetine for adult ADHD. These are all trials done during the noughties, a long time ago. These are old trials, but they haven't ever been Cochrane reviewed up to this. And this group you see here thought they'd do just that. And as far as I could see, having read the review, this was a perfect Cochrane review. They didn't say atomoxetine is wonderful. The clinical trial results show that, well, it beats placebo, sure. Almost exactly the same way as SSRIs do. You know, the results for SSRIs in placebo-controlled trials aren't great. They just barely beat placebo. But this conceals the fact that there's some people doing terribly well who you figure the drug really suits and others doing poorly. The review didn't talk about any terrible hazards the noradrenaline reuptake inhibitors have. All things being equal, looking at it, it seemed to be a thorough and reasonable review. It was very difficult to see why Cochrane rejected it, but they did. And one of the reviewers says, the plain language summary of what we've done here says that ADHD is something that is thought to continue into adulthood. He says, this is insulting to people who've got ADHD and is not the kind of wording we expect in an academic article. Well, the problem here is the trials were all done during the noughties when lots of people, even in the United States, weren't sure that there was any such thing as adult ADHD. And the publications from Lilly will have said, we now think this might continue into adulthood. So the authors weren't inventing anything here. There's a case of history here, which a Cochrane reviewer has no feel for. And a further point that came up in the review was what the reviewers haven't talked about is the links, the comorbid links between ADHD and ASD. The people who've got one often have the other. But this couldn't have happened in licensing trials done for drug during the noughties. First of all, because adult ASD wasn't there at that point in time. Secondly, because when you're doing a licensing trial like Lilly were, you don't have more than one condition in the trial at the same time. But Cochrane turned this down. I think the only way to actually explain it is they were scared about the backlash from people who figure I have ASD and I have ADHD, and some of us figure we've got both. On this theme of both, here's an interesting point. This is about people with Tourette syndrome who you're being told have more than one condition usually. Now, 30 years ago, when I was seeing a bunch of patients who had Tourette syndrome and doing some research on them, they didn't. They all had just the one condition. The problem is the main treatment for Tourette syndrome 30, 40 years ago was a very, very, very low dose of an antipsychotic. It works a treat, but it can cause you, even at that low dose, to lose some focus. And if you're then given a scale for ADHD, which focuses on the word focus, and asking you, have you still got just as good a focus as you think you should have, you'll say, no, it isn't as good. And that gives you a diagnosis of ADHD when you don't have ADHD. You've got the side effect of a drug you're on. But it means you'll be put on a stimulant for your ADHD, which is working in exactly the opposite way as the drug you're being given for Tourette syndrome. And one or other of these drugs is highly likely to make you anxious, in which case you'll get an SSRI thrown into the mix. And one of the other aspects to all this is you're likely, in particular, to end up with an autism spectrum disorder, as you're going to see. And you may, it's unlikely, but you may also have a learning disability. People with tic disorders, Tourette syndrome, didn't usually have a learning disability, at least the ones that came into the clinic to see me. So when you've ended up with 4 or 5 illnesses like this and on a bunch of pills for each of them, you may not be able to work all that well. So, this is a tricky area to be in. This graph shows you, this is almost the end, this graph shows you the increasing use of SSRIs for ASD in the UK over the last 20 years. There's been a tripling of the rate. Now, what's going on here? Because SSRIs are not particularly thought of as being a treatment for ASD. Well, what's going on is brought out by the two colored lines, one of them brownish and the other mauvish purplish. And they look the same. There's been the same tripling of the use of these drugs for these two groups who've got ASD labels. The problem is that the brownish line is in actual fact the numbers of people involved. It's 3-fold to 4-fold greater number. And what you're looking at here is most of the patients who've got ASD have no cognitive issues, or as we might have said, or as the article says, no intellectual deficit. There's a bunch of people with ASD who've got intellectual deficits who are also getting ASD, but the word ASD doesn't mean what it used to mean. It's a condition that probably SSRIs can help to some extent, but it's not ASD. What could it be? Well, the year after Driven to distraction came out in 1992, listening to Prozac came out and did exactly the same thing for the SSRIs as driven to distraction did for the stimulants. Listening to Prozac said people can be better than well on this. It'll bring out their inner Van Gogh. It was crazy. But at least it was crazy as a book which is supposedly about treating an illness. It reflected much more the effects of drugs on certain personality types rather than an illness that has been put right regardless of the personality type you have. When we cure a pneumonia, we don't think one kind of person does better than well and others don't. That's what you're getting with the SSRIs. And it was a very categorical view rather than a dimensional view. Now, when DSM came out in 1980, very few mental health professionals in the US knew anything about extroversion and introversion. They may have heard the words and may have thought, well, the extroverted type is a noisy kind of person, the introverted type is quiet and shy, but that's all that I've known about it. But in Europe, it meant something completely different. It meant the way you handle your anxiety. If you're an extrovert, you share the problem round. You tell your mother about it if you're an extroverted child. If you're an introverted child, you retreat to your bedroom and worry about things on your own. Extroverts tend to be risk takers. Introverts tend to be risk managers. Extroverts don't have as good a focus, but that can be creative. Introverts can be over-focused, and they wish they didn't focus as much and didn't remember as much as they do, that they haven't always kept to the standards that they think they should be keeping to. Introverts respond to SSRIs, extroverts don't. We also know that when you're trying to work out how much drug it takes to put a person to sleep for surgery, extroverts take only a fraction of what introverts need. So this is a worldview that's been lost, and it's an important worldview because it's a bit like football teams. You need the folk who can score goals, and you also need the folk on the team who can stop the other side scoring goals. We need this variation. We don't want to get rid of this variation. It's needed for the teamwork we need in jobs and marriages and countries. You don't want to squash it all out of existence. You don't want to create a situation where young guys in particular, maybe girls these days also, who've got great social skills, could sell sand to the Saudis, who figure, I want to make a lot of money. Where do I make all the money? Well, I go into a big corporation. That's where the money is. Who sit this guy down in front of a spreadsheet on which you have to focus, and he can't. And he ends up figuring he's got ADHD, or his doctor figuring it and putting him on stimulants, which he's able to focus when he's on the stimulants. But at the weekend, when he comes off them, he has a complete crash and turns to alcohol. He ends up rapidly becoming a mess because he's not in the right job for him. And trying to edit this by giving him a drug that will help focus, but it's nothing to do with an illness. It'll help focus whatever you have, or make you over-focused if need be. This is what we've lost. And somehow we need to restore this kind of way to see things. Which leads me to the conclusion that I opened up with, which, well, a bit more than what I opened up with. My sense is that real disabilities in the sense of hardcore ASD and not the ASD that people get labels for these days is increasing. Partly because we're taking more drugs during pregnancy than we ever did before. But also what's increasing is an exploitation of disability benefit systems. And in one sense, you can't argue with this because any system we set up, some people are always going to be able to exploit it. And in particularly, bright kids going to universities are going to look at this and say, well, I can use this. Not all of them, some of them are. And it's also going to be wealthy families, well-placed kind of families who will be thinking about how they can exploit the system for their children. So what you've got is a version of the old Greek saying that the well-placed or the powerful do what they can, and those who aren't so well-placed endure what they must endure, which is called political realism. which is not a nice situation for any of us to be in. We need to somehow change the politics. And on the blog version of this talk, if you are able to comment on how we change the politics, that'd be good to hear. Thanks very much for listening.